Hello and welcome. I'm Susan Solomon, the CEO and founder of the New York Stem Cell Foundation Research Institute, or NYSCF as we call it. Thank you for joining us for what will be a fascinating and hopeful conversation about new approaches to the devastating group of diseases that we call women's reproductive cancers. March is Women's History Month, and in honor of that month, we're going to shine a spotlight on these cancers. Collectively, women's reproductive cancers, by which we mean the group of cancers affecting women's reproductive organs, or below the waist, as I say, have been underfunded and neglected. This has led to an incredibly difficult situation today for patients. Speaking firsthand as a cancer patient and survivor, there are really few effective options for treatment, and the standard of care, while it has changed in some regards, in others it has barely changed in decades. And most importantly, the survival rates are stubbornly lower than they should be. And that's why in 2018, we decided to launch our Women's Reproductive Cancer Initiative at NYSCF, because we have an opportunity with stem cell technology to really change the paradigm of how research is done and identify better treatments and potentially even cures. In addition, we really wanted to target the sad state of affairs with regards to funding and awareness around this group of diseases. I call women's reproductive cancers, ovarian cancer, and other kind of the Me Too of cancers. Fundamentally, this is an equity issue. This is backed up by data. When you account for incidence and mortality, ovarian cancer, for example, gets 20 times less funding than prostate cancer. Me Too and gender inequity doesn't just affect careers, but also diseases and our lives. So we have an opportunity, a great opportunity before us to advance equity in research for these cancers. To that end, we are very fortunate today to have with us expert panelists who are doing some of the most innovative work out there to move us towards higher survival and really equity for this devastating group of cancers. Dr. Ursula Matulonis of Dana-Farber is at the forefront of new clinical trials to discover better therapies. Dr. Sohrab Shah at Memorial Sloan Kettering is a pioneer tackling the genetic complexity of these cancers. And Dr. Laura Andres Martin has led NYSCF's Women's Reproductive Cancer Initiative since its inception. In today's webinar, we really are only able to touch on a small portion of everything we do at NYSCF. And if you're interested in learning more about anything that we discussed, or if you have a particular question, please reach out via our website or through the chat function. I also want to acknowledge the transformative partnership that we've been fortunate to have with the Stavros Niarchos Foundation in making events like today's possible and encouraging others to support our efforts. If you are interested in making a gift towards our education and outreach programs, SNF will generously match your gift one-to-one, and you can visit the link in our chat for more details. So to all of our visionary partners who are watching today, we're deeply grateful to you. Many of our research and discoveries continue to be fueled by your philanthropic support, the majority. For those of you who are new to NYSCF, we look forward to sharing more of our work with you and hope that you'll join us in our mission of accelerating cures for patients everywhere. Our goals with the NYSCF Women's Reproductive Cancers Initiative are urgent. Patients cannot afford to wait, and we really are working tirelessly each day to move this research forward, as are all of our esteemed panelists here with us. And we're very grateful for them to be able to join us and devote the time to have this conversation. We are looking forward to hearing about the latest work. So to get us started, I want to introduce Dr. Raeka Aiyar, NYSCF's Vice President of Scientific Outreach, who also leads our diversity, equity, inclusion, and belonging efforts, to bring on our panelists and moderate this critical conversation. Raeka?
Thank you, Susan. I'm really excited for this discussion today and for the opportunity to mark Women's History Month with a closer look at these devastating cancers for whom progress has lagged, but for which we believe the tide is now starting to turn. Thank you to those of you who have submitted questions in advance, and we encourage you to please add any questions that arise to the Q&A function, and we'll do our best to address as many as we can along the way. I'd now like to welcome our amazing panelists. Let's start with Ursula Matulonis, who is Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and a Professor of Medicine at Harvard Medical School. Ursula, thank you so much for joining us.
Thank you, Raeka. Thank you all for inviting me. It's great. Thank you.
It's great to have you. You're a leader in researching new therapies for gynecologic or women's reproductive cancers, in running clinical trials for new therapies that have the opportunity to change the situation, and in treating patients. So could you start by telling us, how do you approach a patient who's just been diagnosed with ovarian cancer or similar reproductive cancers? What treatment options are currently available for these patients?
Yeah, so certainly when a new patient walks through the door, it's really important to understand where the cancer is coming from. And sometimes we are left with a biopsy to do that. And that's how ovarian cancer has really changed in terms of requiring upfront cytoreductive surgery, where the patient goes to surgery first, to not only make a diagnosis, but to the surgeon physically removes the cancer. But now we've learned that establishing a diagnosis and then treating with chemotherapy, followed by surgery, followed by more chemotherapy, is just as good, as probably even a little bit better, because that patient can be treated with the systemic chemotherapy that they need first. So, and it's a great question. A lot of pieces to that question, but certainly understanding the organ of origin as best as we can, staging the patient. So does she have early disease? Does she have later disease? A specific stage becomes more important for cancers like uterine cancer, whereas ovary, we're thinking about, early disease. Do we need to use chemotherapy? Yes or no? And then for somebody with more advanced cancer, stage 3 or 4, should we start the chemotherapy ASAP? And a lot of times, fortunately, doesn't happen that often, but it definitely happens where somebody comes in very symptomatic. So that's the other really important piece, is talking to the patient, understanding her symptoms, what's been the trajectory of the symptoms, when did they start, are they accelerating, how quickly do we need to start treatment, reviewing all of her radiographics or CT scans or PET scans, MRI scans, mostly CTs or PETs. And I review everybody's CT scans. I review the actual images, and I really get into my brain and my mind what that individual looks like from a CAT scan standpoint. Where's the cancer? Where is it spread to? Where it hasn't spread to? What symptoms or potential issues are going to occur when she's starting therapy? And then, talking to her, talking about, how, not just how she's feeling, but her medical problems. Does she have any coronary disease, kidney disease, other autoimmune disorders, allergies, looking at all the medications. So really understanding that individual and getting that into my note so I can refer to that note as kind of a roadmap when I'm thinking about her. If she's got relapse disease, understanding what treatments she's received already, what's worked, what hasn't worked, what are the dates, what are the side effects she's experienced. So all of that becomes very important in deciding a treatment plan when I meet somebody for the first time, or if they're coming for second opinion, kind of talking about the different possibilities for therapy. So it really, it's an intense visit, and really, trying to be as reassuring to her as possible that we're going to come up with a treatment plan. How do you get in touch with our office, meeting the team, getting a surgeon involved, getting a radiation oncologist involved if necessary, and really kind of walking with her through this journey of a cancer diagnosis, either newly diagnosed or somebody with recurrent disease. And in terms of treatments, so you asked me about treatments, do we not have to use treatment? Is it early enough cancer that we can forego systemic treatment? Will it be chemotherapy? Will it be immunotherapy? Or will it be a clinical trial? So that is all decided and discussed, at our first visit, but then periodically as her history unfolds.
Well, that really is a complex journey, and thank you for everything you do to guide women through that process. I want to, we'll come back to some of those options that you mentioned and the complexity of that. But I'd next like to welcome our second panelist, Dr. Sohrab Shah, Chief of Computational Oncology at the Memorial Sloan Kettering Cancer Center here in New York. Thank you so much for joining us, Sohrab. We really appreciate you being here today. As a leader in computational oncology, you specialize in using computational methods to understand how these tumors evolve and respond to treatments. Especially, this is really important for cancers with really complex genetics, like the ones that we're discussing here today, and we'll delve into that. But can you tell us, how do you take that on? How do you tackle approaching these complex genetics of these reproductive cancers, and what are the challenges that you face?
Yeah, well, first of all, thanks for having me, and it's an honor to be on the same panel as Laura and Ursula here, and thank you for hosting this important event. So I'm a scientist, and so I'm inspired by Dr. Matulonis's comments and what goes into treating the human being. As a scientist, we tend to look at something that's much more dispassionate than that, and which is to say that we really try to understand the molecular states of these cells that have gone awry, and so this is high-grade serous ovarian cancer, which is the main, most common type of ovarian cancer and the most difficult to treat, is a disease that is exceedingly complex. And so in addition to it being a clinical challenge, it is a scientific challenge as well to really understand the biology of this disease. And the defining feature of the state of these cancers is a mutation in a very key gene that in human cancers called TP53. And almost all of these high-grade serous ovarian cancers have a mutation in this gene. And essentially what a mutation is like, you can think about it as a spelling mistake in the genome or the DNA sequence of a cell. And if that spelling mistake happens at just the wrong part of that, of the text of the DNA, then the behavior of the cell can really go askew. And that's really what happens here is just the one gene being dysfunctional allows for a cascade of changes in the genome to accrue. So we like to think of TP53 sometimes as a gatekeeper. And so once the gatekeeper is gone, then all kinds of chaos can ensue. So that has two implications. One is that the rest of the genome of those cells accumulates many changes, and this can look like random patterns and really scrambled genomes. So you can imagine a textbook or a book or something like that that's being replicated, and the pages are all in the wrong order, and they're upside down, and they're backwards, and this is what happens. And so when we analyze the genomes of these cells, it's quite remarkable that even these cells can live, given how disrupted they are. So that's one implication. And then the other implication is that every time a cell divides, so that cancer cell divides, it has to replicate that DNA. And so every time that process happens, new mutations occur in the genome. And so what the implication of that is that every cell in that cancer actually is a little bit different. And so when we try to treat a cancer, the majority of cells might succumb to a particular treatment, but there are some that can withstand that treatment. And those are the cells that typically grow back when the patient relapses. So how do we deal with that? the DNA sequencing technology has advanced to really an incredible pace, where we can now analyze or look at the genomes of individual cancer cells, and thousands of them at the same time. And we're able to recognize patterns in these cells. And that's what machine learning and computer science allows us to do, is take these very large complex data sets and actually derive patterns. And what we're finding is that these different patients, we can start to group patients based on the pattern of alterations in their genomes. And this is not only a biological grouping, but these patients respond differently to treatments. So it gives us a clue that by synthesizing all this very complex information, we can start to then group patients into biological groups that potentially can be stratified into treatments, and where personalized medicine, personalized approaches can be implemented, and that gives each patient a better chance at an outcome than just using a broad strokes across all the population. So perhaps I'll leave it there, and I'm sure there's more to follow up.
Definitely, we will certainly circle back to the concept of personalized medicine and how that's helping to change the paradigm for a lot of cancers. But for now, last but not least, I'd like to welcome on our NYSCF's own Laura Andres Martin, our research investigator in oncology who leads the Women's Reproductive Cancer Initiative here at NYSCF. So Laura, could you tell us a little bit more about the opportunities in stem cell technology that you and your lab are exploiting to study these cancers in a whole new way?
Yeah, thank you so much, Raeka, for that introduction. I echo Sohrab's words. It's an honor to be sharing this panel today with Ursula and Sohrab as well, and to be invited to discuss about this important problem and what we are trying to do to perhaps accelerate the improvement of these patients' outcomes. So in our lab, and the approach that we decided to take when we started our program here at NYSCF is on the point of view and the concept of how can we actually study these tumors without having to do something as a snapshot, without having a tumor sample that has a finite lifespan in a way. And we wanted to incorporate technology that enable us to extend the lifespan of these tumor samples so that we can actually do many different studies, understand the complex biology, and we do that in a way that is also personalized because of the complex biology of the tumor's heterogeneity. As we are going to discuss probably later, there is no two patients that are similar, and even within the same patient, the complexity of the genetics that Sohrab was describing, for instance, is extremely complex and not similar between two tumors. So the scientific community has been very fortunate on this stem cell technology to become possible in the past few years that has been incorporated into modeling tumors, not only for ovarian cancer, for other tumor types as well, but that we decided to implement in our lab. This is driven by leveraging the learnings that we have from stem cells that reside in our tissues. And what this technology allows us is to really, again, prolong the lifespan of these tumor samples in a way that we can grow them in the laboratory almost in an infinite manner. We get the tumor samples from surgeries from patients through collaborations that we have with clinicians, and then we literally grow the tumor sample for that specific patient in something that we call organoids. And this way to grow the tumors, which is as opposed to what we were doing classically, growing cells in a dish that need to be adapted into this plastic environment. This way to grow the tumors in this organoid manner is a more physiological way to grow it, meaning that we had been able to recapitulate more faithfully the environment in which these tumors grow in the patient. So when we do that in the laboratory, we can actually now reproduce the tumor in a similar manner to how it grows in the patient. So that means that we can actually now have a tumor that is growing in the lab, and we can make different approaches to not only understand the biology, but also to take into functional assays so that we can make interventions in this tumor that we have in the lab and try to make predictions to whether that can be actually extrapolated to the patients. So one of the advantages of these models, for instance, is that if you apply the drugs in the dish to these tumors, there has been evidence that is building over the years, not only for ovarian cancer, for other cancer types, for this cancer in particular, that for certain drugs so far, when you apply this drug to this organoid model, they can recapitulate the patient's responses in the clinic. So this is something that us and others, we are building on this evidence that we can actually use these models perhaps in the future as a surrogate of a clinical trial for candidates drugs, and really to take into that promise of personalized approaches and the hypothesis that we generate based on the genetics or based on other clinical aspects. We can actually have a mean and a tool now to do a testing in the lab and incorporate that as a new information that can be taken into account when considering the complexity of a patient treatment. So we're trying to really contribute to this, building this knowledge of what the cancer of a specific patient looks like under the point of view of the clinical standpoint, diagnosis standpoint, and then we have studies like what Sohrab and others are doing on the genetics standpoint, and we want to take it into hopefully a little bit different, another level of information, which is what if we test the hypothesis that we may drive in our heads with all this information, and we can actually test it in the lab with this model, and then incorporate that information into hopefully the treatments of the patients. So by doing this, again, we are creating collections of organoid models that are personalized for each specific patient, and trying to keep building and expanding more these collections to capture really the complexity across different patients on different levels, genetically speaking, but also with other different genetic backgrounds that are also important to capture, and trying to also incorporate these population scale studies that are also important for improving outcomes in clinical trials.
Right. So really, really helpful kind of avatars of the tumor that you can use to kind of keep studying and trying different therapies out on. And we'll come back to that concept in a bit. But for right now, I want to talk a little bit about the concept of equity, because we are here to mark Women's History Month, as Susan mentioned. And it's important to be mindful that a lot of the challenges that we're encountering in these cancers are really equity related. So for example, accounting for incidence and mortality, we have 20 times less research dollars in ovarian cancer than we do for prostate cancer. Less research dollars means slower progress towards treatments, means fewer treatment options available, and means that the outcomes are much worse than they could be or should be. And even as one audience member pointed out, that mortality improves for other cancers, but it's not doing so at the same rate here. So I want to ask all of you, sort of, what do you think are the major factors or challenges that are driving these disparities? And are we seeing improvements? Ursula, would you like to start?
Yeah, I'm happy to. So I really agree. And I also want to mention how honored I am to be here today as well. I didn't get to say how much I enjoy seeing you guys, and it would be fun to do this in person, but not quite yet. We're getting there.
Yeah,
getting there. So I think, yes, I concur. And I think, a striking feature, which the 2022 numbers came out in terms of looking at cancer survival. And there are two cancers that have worsening survival. So all the other cancers have improvement in survival. The two cancers that have worsening survival are uterine cancer and cervix cancer. So both GYN cancers. And it's very difficult to find uterine cancer foundations. There's not a SPORE for uterine cancer. There's not DoD funding for uterine cancer. And that exists for ovarian cancer, and cervix cancer is very few funding mechanisms as well. So I concur, and I think what draws researchers into specific fields is the presence of funding, because mice, people, reagents, time, it costs money, and we need funding to lead to research projects. We need discretionary funding, small amounts of funding to kind of seed funding that leads to small discoveries. And the NCI and the NIH are not going to fund great ideas, but they're going to fund ideas that have led to very promising scientific results. So I agree. There's a big discrepancy here in the funding that goes to GYN cancers. Uterine cancer, not only, the numbers are increasing, death rates are decreasing. There's a significant racial disparities problem with Black women having worse overall survival than white women. So we have a lot of work to do.
Yeah, certainly. Sohrab, did you want to add to that?
Sure. I think the other, I would say, in addition to Ursula's comments, I would say that ovarian cancer, it's actually particularly challenging because DNA sequencing has really helped a lot of other cancers where we've identified mutations in specific genes that could then be developed into drug targets, and so that's been very successful in many other cancers. As I mentioned earlier, that this really is a cancer of the genome, not of particular mutations, and so we really need to analyze the whole genome, and that tends to be quite expensive. So to make progress, we actually need more dollars per tumor in this disease than we would otherwise, and so it's a double problem. But what we've been trying to work on, and many other groups are as well, is to really show the value of that. And in the grand scheme of things, knowing the state of the whole genome, that's actually a small expense in order to incur, because the treatments are expensive and we want to match up the treatment to the right patient. And so I think those dollars are well spent if they are successful in matching the patient to the right treatment. And so, but we need to do the research now up front in order to get to that stage, and that is an expensive endeavor, and so we're pushing hard to try to raise funds for that type of work.
Absolutely. I mean, we're certainly seeing some types of awareness efforts and new research efforts. What kinds of things, and maybe Laura, you can start, do you think are most likely to have an impact on changing the situation?
Yeah, definitely. I think, I want to also elaborate a bit more on what Sohrab was saying in terms of how very often when the biology, the increasing awareness is one thing, but at the same time also it's a very complex cancer, and sometimes you need the research results to really also drive this competition during grant funding and all these things. So we don't have the research is not done because there is not enough awareness of people interested on when the biology is so complex that it takes longer to really understand what's happening.
Right,
Then
like
we enter
cycle.
into this vicious cycle, where how do you actually show that there is a promising quick turnaround of these results into something that is translatable? And that has been accumulated probably over time. I think initiatives like what we're just talking about, discussing increasing this awareness, having this initiative like us, that we really try to bring this problem into the conversation on the table and really bringing more awareness to the actual problems and the challenge, as well as more dedicated research to ovarian cancer, in particular and other gynecological cancers, by taking up on that challenge of how difficult is work with this tumor type because of the complex biology, and there will be always a more difficult understanding. Modeling the tumor is very difficult as well, but taking up on that challenge and just keep moving forward to keep advancing, I think will be things that will probably have an impact on resolving some of these issues.
Right, and we did see this happen with breast cancer, for example, where major awareness campaigns were able to raise more research funding, and we did see the situation change for those cancers. So Certainly lessons to be learned there. Ursula, you had mentioned the racial health disparities as well. For example, Black women having twofold higher mortality rates for both endometrial cancer and breast cancer than white women, and Black men being twice as likely to die from prostate cancer. So we see this like really across cancers. What kinds of initiatives and research are helping to change this situation?
Good question. I think a lot of the research has been focused on identifying the problem. So, for example, one of our radiation oncologists has looked at access to brachytherapy and access to radiation therapy for patients with either uterine cancer or cervical cancer, showing that it's harder for Black women to get access to these different treatments. So I think, and there's, not following standard of care. There are other studies that have shown in terms of, access to a G1 oncology surgeon varies. So there's certainly an access to care problem. And I think a lot of hospitals, certainly we've done it, Memorial has done it, is to try to position our faculty, our physicians, our services within different parts. So set up satellite centers, set up offices of equity and diversity, and really have significant, strong research programs and access to care programs. And I think the National Cancer Institute has put a very large emphasis when National Cancer Institute funded cancer centers are given, grants and renewals of the cancer center grants, that we have to show, we have to be doing adequate research and efforts in this incredibly important entity. And then secondly is to study the biology of the different cancers. Are there differences in different individuals who have these cancers? Do Black women have more aggressive cancers than white women? Do certain populations tolerate chemotherapy better or worse? So that we can ultimately individualize care to different patients, not just based upon type of cancer, but also understanding different ethnicities, different races, and how there's response to treatment.
Right, and the genetic variants that might show up in certain populations that
Absolutely.
we're not
Absolutely.
capturing with the research, because most of research is being done on predominantly white populations, and so you kind of miss that section of the population.
I would add that there is a strong influx of energy and work into the role of genetic ancestry, as certainly at Ursula's colleagues and Dana-Farber and my colleagues here at Memorial. There are really fascinating findings actually now that are emerging, where genetic ancestry, as defined by variants in the genome of normal cells in an individual, can have an impact on what mutations accrue in the cancers, and so that really does suggest that the genetic ancestry of individuals can be a determinant of the type of biological properties of the tumor that evolves. And I think that's just a very brand new emerging field. I think there are talented people working in that area. There's a program in New York called the Polyethnic 1000, which is now branched out across actually multiple states. That's initiated by Harold Varmus and Charles Sawyers, and to really try to study the genomes of individuals from different ethnic backgrounds. And it's really gaining momentum, and we're learning a lot from that program. And so that's just one of, I think, several efforts around the country to address this, and indeed around the world. I think this is an international concern, and it really is it's an open scientific area, and also has obvious societal implications as well. And the equity issue is multifaceted, as Ursula mentioned right off the bat, and so much of it is due to access to care. But we're also really understanding these biological differences as well.
Right, and there was actually an open a question from the audience about, could we foresee an open database sometime of DNA variants and mapping those to treatments, and it sounds like that's where the momentum is moving towards, which is really great. Laura, I wanted to also just ask you to talk about the biobank that you're building of organoids and how that can help to address some of this.
Yeah, I wanted to elaborate on that, and also mentioning that I think, as Ursula was saying, it's a great statement. We were thinking about it for a long time and nothing was happening. But I think now, like, we can really see how many initiatives are taking action, and these genetic studies are very excited to see what will come up from that, because we really, I think there is a conjunction of technologies that has been from early stages of, like genomic sequencing 20 years ago. It was kind of this revolution, and wow, it was taking forever to maybe do one sequencing, but technology has really advanced as we move forward on the research, and we keep working on it all together from different disciplines, so that now sequencing is something that you can just do in a sprint, and probably so I can speak about that. At the same time, with the technology that we are utilizing our lab and others on modeling these tumors with this three-dimensional structure and disorganized, that is really growing the tumor of the specific patient in the dish. You can really now have a representation in this collection of organoid models that represents everybody in an individualized manner. So that, of course, also will incorporate these genetic differences, and we can then take on that and then do the functional testing, apply drugs or potential combinations, and see what is the outcome and how can we correlate that with the genetic footprint for each one of these different models. So we are excited about trying to do that. Since we receive samples for patients, we don't have a selection. We live in New York City. We are fortunate to live in a diverse city that also have access to patients that are of diverse ethnicities, and we are hoping that with our collection we can actually have a good representation. It's going to take time because of recruitment and how the logistics of patient recruitment works, but we are hoping that our collection will have a good representation that can represent the tumor types in different levels, including these ethnic differences.
Absolutely. Well, that's great. Let's turn to the next generation of treatments that are on the horizon, since we have a lot of exciting things underway. So Ursula, I want to start with you. Can you talk about some of the most promising types of clinical trials that are either underway or imminent? And particularly, there have been questions from the audience about those whose treatments have failed in ovarian cancer, or those who may have had some initial success, but of course, as you all discussed, the relapse and resistance is really common. So what's on the horizon for tackling these issues?
I mean, I think the treatment of increasingly resistant cancer is a challenge, and I think it has to be thought about in different ways. And I think you've heard from Dr. Shah that for most of our patients with ovarian cancer of high grade serous ovarian cancer, that there's not a druggable mutation unless somebody is found to have a BRCA mutation. So for anyone who has an diagnosis of ovary, fallopian tube cancer, or primary peritoneal cancer, they undergo BRCA testing, which is expanded. Sohrab already mentioned that the cost of sequencing has dropped down, so that makes it really doable for all of our patients, and that's a universal recommendation. So certainly, as we're thinking about new treatments, so again, ovary cancer, PARP inhibitors have been instrumental, certainly instrumental the most in those who have a deleterious or abnormal BRCA mutation, and that can either be someone who's inherited that mutation from either mom or dad, or the cancer specifically just has its own mutation. And certainly for folks who are newly diagnosed with advanced high-grade serous ovarian cancer, it looks like the introduction of PARP inhibitors during maintenance treatment post chemotherapy has really been a significant game changer and really has improved how women do. It's also improved how folks do in the recurrent setting as well. The challenge has been trying to figure out how we deal with the cancer when the drug becomes resistant to a PARP inhibitor, and that's where genetics is really going to help. Immune therapies, single agent checkpoint inhibitors, the ones that you see on TV, haven't been a home run necessarily in most of our women with ovarian cancer, but there are different immune strategies being attempted. So there are different therapies. These are drugs called bispecific antibodies, where the antibody targets typically different immune cells and brings them together. Normally they're not in the same neighborhood, but you bring them into the same neighborhood. Different vaccine studies that are being attempted. And again, a lot of work on basic immunology and how we can try to reignite the immune system to target an ovarian cancer cell. Another type of medication that is near on the horizon are drugs called antibody drug conjugates. So it's an antibody, so it's the Y, and that open Y hooks onto a protein that's present on the cancer cell, and that Y, that antibody, drags with it a small drug, anti-cancer drug, and brings it theoretically directly to the cancer. And there are a number of antibody drug conjugates that are being tested in ovarian cancer, but also in uterine cancer, as well as in cervix cancer as well. For uterine cancer, immunotherapy has become more standard of care and we think about women with uterine cancer in terms of sort of those cancers that would be very sensitive to an immune checkpoint inhibitor versus not, but immunotherapy for those patients who have recurrent disease has become much more standard. And in cervix cancer, we've seen the treatment of cervical cancer change rapidly in just a few months over the summer of 2021 to fall of 2021, where the use of immunotherapy has gone from somebody who's very heavily pretreated with recurrent cervix cancer into the upfront management, so combined with chemotherapy. I'll make one more point and then let others speak, but I think the importance of histology, we talked about high-grade serous cancer already, but low-grade serous cancer of the ovary, a cancer that can be very sensitive to hormonal therapies like aromatase inhibitors. There was a recent paper that just came out a few days ago using a drug called a MEK inhibitor. And MEK inhibitor combinations are being tested for low-grade serous cancers. In uterine cancer, there's a type of endometrial cancer called a serous endometrial cancer. It has the same name as ovary, but this is a very specific subtype of endometrial cancer where the recurrence rates are higher, and different therapies are being tested. WEE1 inhibitors, somebody asked about P53, targeting P53. It's been hard to do, but when you target a cancer that has an underlying P53 problem and you put on a drug called a WEE1 inhibitor, something called synthetic lethality can occur, meaning two genetic hits sort of makes the cancer cell, fall apart, whereas just one or the other doesn't work as well. So there's just a lot going on, and it's a very exciting time, lots of clinical trials going on, but still a lot of work to do.
Thank you. These are really, really promising updates. Sohrab, is there anything that you want to add? I saw you nodding about immunotherapies, especially, and things that you're learning from your research.
Sure. I mean, I think far upstream of actual clinical application, we're really trying to study the elemental biology of the disease. And Ursula's, kind of a superhero of clinical trials, and it's really advancing these exciting new therapies. We're working upstream to try to understand why they work and why they fail. And what we're uncovering is really that, especially with immunotherapy, these ovarian cancers are quite tricky in that they can find multiple routes to immune evasion, what we call immune evasion, or where these cancer cells can hide from the immune system that should be able to eradicate them. And this is another example of the complexity of this disease. Is what we're learning is that these different types of DNA repair deficiency, which creates these patterns in the genome, actually relate to how these cancers then hide from the immune system. So there's a link between what's happening in the genome and what's happening to avoid immune surveillance. And so that's quite promising, because it suggests that if these patterns and properties hold up, that we could identify these tumors and then use these different classes of immunotherapy that Ursula outlined to potentially advance the treatments. But we're far from that. But I would just say that in the discovery space, we're very much starting to key in on it's not just one way that these ovarian cancer cells hide from the immune system. There are multiple ways, but these are reproducible and they're detectable. So I think that's a good progress in that space, and we'll see how we can work with people like Ursula to translate those findings.
Absolutely. Well, immunotherapies is something we've heard a lot about in terms of blood cancers, and really kind of revolutionizing the way that those cancers are treated. We haven't quite seen that happen yet for these cancers, for reasons that you've been talking about. What do you all think it will take to bring these therapies to reproductive cancers? What kinds of efforts on both the research and clinical side do we need to see?
Laura, do you want to tackle that from your standpoint? And then
Yeah, why don't you start with the organoids? Yes.
Yeah, definitely. Yeah, I was. The answer is going to sound very simple, but we actually just need to do the work. I think we just started to grasp on taking on these new technologies and new treatments in the ovarian cancer space. For many years, everything seems to was like a stall on. Nothing was happening, no new treatments. But as Ursula was describing, the horizon is bright. There is so many things going on, but we don't know much about how is this going to work specifically for ovarian cancer. Immunotherapies for solid tumors or cellular immunotherapies for solid tumors are challenging themselves. We haven't even started to explore how is this can be applicable, or just starting to explore how that can be applicable for ovarian cancer. So from our side, we really want to leverage the technology that we have implemented with the organoids to try to utilize them so that all the things that need to be understood, or all the things that are being tested in clinical trials, is there is a way that we can use these models to have those answered a little bit faster and trying more things. Clinical trials, of course, they are definitely the way to go, but there is a limitation on the amount of things that perhaps you can try. And there is a limitation often on the amount of patients that get allocated into this specific setup or experimental condition. So can we combine the preclinical modeling and these preclinical platforms where we can actually perhaps test infinite or many combinations to accelerate how these therapies develop, so that the clinical trials can be designed perhaps in a much more efficient manner, or we can allocate specific patients along with genetic information, functional information. Can we discover and stratify patients that maybe are going to respond better to some of these therapies, including immunotherapies? So for immunotherapies in particular, the last thing I want to mention is that there is a lot of excitement and a lot of next innovation in organoid modeling, which is incorporating also components of the tumor microenvironment, so that we can actually...
Could you explain what that means?
Right. Yeah, so the tumor microenvironment, the tumor is not only the cancer cells alone. A tumor is composed by many other things that accompany the tumor. The tumor like to be located in this specific space in our body, and then there is a cross education in between tumor cells with that space where it's located, so that there is what we call the niche where the tumor really can prosper. And again, like the tumor makes these changes around it so that it can really foster itself to grow and expand and spread. So that's what we call the tumor microenvironment. There is cell types that are specifically associated with these tumor cells that are part of this tumor microenvironment, and they are going to foster and nurture the growth of the tumor. But there is also these other molecules, factors that are around the tumor, surrounding this environment, that also represent like signaling and or are creating this like immune suppressive environment in a way that the immune cells, for instance, cannot see the tumor because of this. They create like this shell
Like a shield.
where they become invisible, right? So with organoids, we are like trying to also like implement these innovations into incorporating other cell types, because everything contributes to how the tumor is going to respond or is going to evolve in response to these drugs. So that's another aspect that is just starting to happen roughly, and very much will also provide a better understanding and a better modeling for testing, in particular cellular immunotherapies and other aspects.
And by cellular immunotherapies, you mean things like T cells that we've seen used, CAR Ts that we've seen used quite widely for leukemias and myelomas and so on. Exactly. Are there other types of cells that might be a bit more effective in cancers like ovarian?
Yeah, classically, T cells has been used from the beginning. There is some other cellular types that are coming into play recently, such as what we call these natural killer cells, for instance, or myeloid cells that can be used. We can study them under the biology point of view to understand how do they surveillance, how do they attack the tumor or contribute to actually tumor evolution by other mechanisms. The complexity is high, and so I can speak about that probably better than me, on how the different cell types can have a positive action but also a negative action. But besides that, in addition to T cells, there is also now a shift into trying to leverage other cell types that has different and distinct advantages, as opposed to maybe T cell therapies that are dependent on a specific target, which means like a specific proteins that are expressed in the tumor, so that it maybe limits the widespread application of that cellular therapy. In particular, there is some challenges that we need to resolve in terms of toxicity, side effects with T cells. Some other of these immune cells are coming into play because they represent separate and distinct advantage that overcomes some of these challenges, like natural killer cells. Supposedly, they may be better at penetrating the solid tumor. They may have less toxicity effects, and we can really leverage on those aspects to try to apply them as an effective therapy for ovarian cancer. And we are excited to work on that aspect as well as from our lab.
Well, natural killer is definitely the coolest cell name that we have in our repertoire. Sohrab, Ursula, do you want to add anything to that about the sort of promise of immunotherapies for these cancers?
Well, so one thing that comes to mind is that what we would like to do is marry the type of very rich molecular and computational profiling that we engage in tumors that are extracted from patients that are just part of regular treatment, and actually engage in those studies on actual clinical trial specimens, and that has proven to be quite difficult to do. And so, because the clinical trials tend to be very controlled, and so for good reason. But what we would, I think, what would advance the needle is to be able to work with those samples from clinical trials in a way that is very rich and detailed, so that we can really do the correlative science that can explain the response, positive or negative, of patients that are undergoing these investigational treatments.
To finding the genetic keys to that response. Okay,
I was just answering some of the questions in the chat. I wanted to clarify some of the issues. I think immunotherapy is being worked on, and certainly in ovarian cancer, we have a vaccine trial of a neoantigen, so new protein vaccine study that's taken us many years to get off the ground. It's part of one of our NCI-sponsored grants. And we've just started vaccinating our patients who have either newly diagnosed advanced ovarian cancer or first recurrence. And then we also are working on a natural killer cell protocol. But these take lots of efforts from our surgeons, from our clinical research team, from a place called the Broad Institute, which is in Cambridge, because you have to, for the vaccine trial, sort of call or name the new proteins and sort through all the different proteins within the cancer and say, okay, what's new and what's not new? What are we going to build the vaccine to? What we're not going to do? And that takes time. So it's a lot of effort, but I can certainly reassure everyone on this webinar that there are just large teams of individuals, and you're seeing several of them on this call today, who are working diligently despite the pandemic. The pandemic, I don't think, has slowed anything down, really.
No.
To get work done, to understand biology better, like Dr. Shah is doing so wonderfully with this group at Memorial, and then building better treatments like we're all trying to do.
Well, that is a really nice closing sentiment, Ursula. I want to give Laura and Sohrab an opportunity to also just say, kind of what the most kind of inspiring case or example you've seen of innovation lately that makes you hopeful right now.
Yeah, so I think we're really understanding now these different ways in which these cancers genomes go awry. We used to sort of put them all into one big bucket, and what we're realizing is that in fact there are different patterns, and that there are not that many of them, and for which there are new drugs available that can target these biological mechanisms. And so I actually think that we're sort of maybe heading to a watershed moment where we can start matching patients up to these investigational agents and making breakthroughs. And so I think it's actually going to be an exciting 10 years ahead.
That's great to hear. Thank you. Laura.
Yeah, just to close on that, the same, I think we're in a prime moment. There is so many things that are happening right now. And I every time I open new literature, new findings are being discovered before it was kind of more, again, stale or very slow discoveries. And, with PARP inhibitors, we have a big, huge differences in how patients are treated and outcomes. And now we are seeing a lot of many different drugs that can actually, sort of referred to that before, how can actually be more efficient for the other patient population that is really not suitable for PARP inhibition. And we will see some developments of those drugs coming up very soon, actually. And then bringing together all these technologies, understanding the biology, like a lot of us are working on it, and a lot of research is being conducted and being done, and a lot of things opening. It's really exciting to see how, all the research that we all together, it will have positive outcomes for sure. And there is more and more things happening, and technologies that are really state of the art and the latest that we can do for not only modeling tumors, but for understanding the biology. We are all bringing that into the ovarian cancer space, which before maybe was lagging behind in utilizing these state-of-the-art technologies, while now we are really incorporating those for studying these cancers. And I think that is very exciting with the prospect of what we can actually do. The technology is amazing. And I think there will be, in the short term, there will be very good developments and outcomes from all these studies.
Yeah, it sounds like there's a lot more technologies, a lot more clinical trials underway, and this is a really good time to be hopeful. So it's been an honor to be among you and to be able to share this space and this discussion today, and to hear the amazing work that all of you are doing. So I really want to thank you so much for all of the work that you do every day to enable better treatments, and for sharing your time with us today. I also want to thank all of our audience members for their questions, which we tried to address to the best of our ability, and for your participation in this discussion. I hope all of you stay well, and we hope to see you at a future NYSCF event. So thank you again.
Thank you very much.
Thank you.
Thank you.
Take care. Thank you.